Go ahead and introduce our next presenter. You've been hearing about getting these medications and all the advantageous things that they can do. Now we need to figure out how we get them. How do we navigate things like prior authorization? What are the barriers that might be there in between getting those medications to where they need to go once somebody's coming out of the hospital? So we're really fortunate to have a segment here today from our very own CareOregon Pharmacy Clinical Supervisor, Jason Malari, who's got great insight into all this today. Jason's a clinical pharmacy supervisor. He enjoys spending time with his children and has also confessed to being an avid gardener. Please give your attention here before our Q&A to Jason Malari.
Thank you, Paul, for your kind words. And good morning, everyone. My name is Jason Malari, and I'm the pharmacy clinical supervisor here at CareOregon. Today, I'd like to go over some challenges of initiating the newer heart failure medications, as previously discussed, from a health plan pharmacist perspective. In my talk, I would like to briefly cover topics such as barriers to access in initiating medications, in particular heart failure medications, but really this can be applied to general medications as well. And in particular, the issues that arise from prescriptions and pharmacy and coverage as patients are initiated on these medications in a hospital or clinic setting. Then I would like to transition over to discuss CareOregon coverage of these newer heart failure medications and the difference between Medicaid and Medicare coverages and PA criteria, and then wrap it up with some general PA pearls or guidelines to help streamline the process. So when a medication is initiated in the hospital or clinic, there can be issues with faxing the prescription to dispensing pharmacy or handing the hard copies to their patients. So it's good to confirm that the prescription was received. Oftentimes, the electronic faxes will give a confirmation that the pharmacy had received it. So it's good to check that. Incorrect drug quantities or directions can be an issue, as dispensing pharmacists will require a clarification or correction of these issues from the original prescribers. And that can be often challenging if the prescriber is a hospitalist or a specialist such as a cardiologist. Insufficient refills can be an issue when a follow-up is needed for titration or dose adjustment purposes. So it's important to give enough refills for the patient for their next follow-up visit. But overall, it's important to consult with your transition of care team if it's available at your facility, or a pharmacist to do a med review or med rec to ensure the accuracy of these prescriptions and that there's no issues with the active medication list, as these can delay the initiation of these medications. It's also good to have a follow-up appointment or a phone call by your staff to ensure patients receive their medications without any issues. When it comes to pharmacy-related issue, prescriptions can be sent to the wrong pharmacy. So it's important to make sure these prescriptions are sent to the patient's preferred pharmacy. Usually, when a patient prefers a pharmacy, it's because it's closer to their place of residence, or they have a better connection with their pharmacist. So sending these prescriptions to a different pharmacy can sometimes delay that process of getting that medication to the patient. However, if a preferred pharmacy happens to be a mail order, then it can also be an issue. It can cause a delay in the delivery of that medication. And I know with these heart failure medications, the patient needs to start it right away. So preferred pharmacy is not always the right pharmacy, essentially. And another scenario is when the prescription is sent out to out-of-network pharmacy. This actually is more of a common issue than people think. So when medication is sent to out-of-network pharmacy, the medications are not going to be covered. And when a patient complains about really high costs of their medications, it's a good indication that perhaps the prescription was sent to an out-of-network pharmacy. And medications can be out of stock. This can happen from time to time, but with the supply chain issues and shortages, it can be a problem. If a patient is discharged also from a hospital towards the end of the week, then sometimes these prescriptions can be sent to the pharmacy with off hours, or like they may have limited opening time on the weekend. So that can delay the delivery of these medications to the patient. So overall, it's important to start these medications in the hospital. If there's a meds to bed program, it's good to utilize that. Otherwise, sending these prescriptions to the hospital outpatient pharmacy or the clinic pharmacy is preferred, because if there's an issue, it can be identified in a timely manner. It can be addressed there before the patient is discharged. And since I'm a health plan pharmacist, medication health plan coverages is something that I do see from time to time, more often than the other issues. But these issues can be perceived when a medication is a non-formulary, or they require prior authorization, or if a member cannot afford their copay. With Medicaid patients, they shouldn't have to pay a copay. And for our Medicare patients or CareOregon Advantage members, we have extended a zero copay benefit for maintenance med. So if a patient is complaining about the cost of their medication, it's usually because, like I said earlier, it's sent to an out-of-network pharmacy, or it could be non-formulary, or it's requiring a prior authorization. So those are kind of good cues to figure out that the medication may need a follow-up. So from time to time, we'll get a new member into our plan, and that can also have an issue with their coverage if their current heart failure medication is non-formulary or it requires a prior authorization. But we do have a 30-day overrides for our Medicaid and Medicare patients on these. So it gives time for the provider to work through our formularies and prior authorizations. So overall, it's good to utilize formulary options and initiate the PA process early. And in the meantime, there are free trial cards from manufacturers. We also offer level of care overrides. So when patients are discharged from a hospital, or some facilities also offer compassion fills, which can cover these medications as the PA process takes place. And speaking of PA-related issues, according to the American Medical Association survey done in 2020, prior authorization issues were perceived to cause 94% of delayed care. I can assure you, as a health plan pharmacist, that's not the intention of formulary and prior authorizations. It is there to encourage use of guideline-based medications and also to decrease costs and to support safety, and thereby improving patient-related outcomes. And now I'd like to go over our formulary with these newer heart failure medications that was covered in previous presentations. First, with Corlinor, this medication is covered in both the Medicaid and Medicare line of business. They do require prior authorization. With Medicare, we are requiring that it's used for the correct FDA indication of chronic heart failure with ejection fraction of equal to or less than 35%, heart rate of equal to or greater than 70 beats per minute, and a maximum tolerated dose of beta blockers, ACE/ARB, and aldosterone antagonist. And for OHP, the only addition to that is that we require that the medication is prescribed by a cardiologist, and that we added the maximum tolerated dose of ARNI as well into the criteria. And the second class of medication is the angiotensin receptor neprilysin inhibitor, or Entresto for short. This is also covered in both line of business in the Medicare and Medicaid. In Medicare, this medication is covered without prior authorization. So it's good to note that if your patient is in Medicare, it should just go through automatically. However, if a patient is in Medicaid, they will require a prior authorization, and the criteria simply ask for that the medication is prescribed by a cardiologist, that they have a NYHA functional classification of 2 to 4, and heart failure reduced ejection fraction. Or it could also be used for HFpEF, as long as it's documented that they had a hospitalization within the last 9 months. And then the third class, the SGLT2 inhibitors, it is also covered in both line of business. So in Medicare, Farxiga and Jardiance are both covered without prior authorizations. So like I said, these are, if your patient's on Medicare, the prescription should go through without any issues. And if it's in Medicaid, only Farxiga is in the formulary, and it requires the prescription to be prescribed by a cardiologist, and we also do require the NYHA classification of 2 to 4 in the criteria. So there's a kind of a little bit of a difference there. And just looking back at kind of the general standard requirements for submitting these prior authorization for these newer heart failure meds, we do prefer that these prescribed by a cardiologist. And then as for the right heart failure type, so whether it's HFrEF or HFpEF, it's good to indicate that on these PA submissions. And the NYHA functional class is also required, and current LVEF, of course, indicating what medications have been trialed and failed is good to have. And of course, in adding the appropriate chart notes to support the PA, I would say this is almost kind of necessary. We do see from time to time a PA submitted without any chart notes, or a PA submitted with chart notes that has nothing to do with the prior authorization itself. So it's good to have these information included with the PA applications. And overall, some of the tips that can help streamline the prior authorization process. So it's good to have a health plan website, a link for CareOregon as a quick reference to know what is currently on our formulary, or if there's any changes in the prior authorization criteria. And it's good to check with your facility if there's a process or there's a plan involved with prior authorization submission, communication, and follow-up. And it's good to also initiate prior authorization through the proper personnel. I've heard from several clinics and health systems that PA application can sometimes go to different people. So it's good to have more of a consistent person to submit these. So maybe a PA coordinator or a pharmacist, so that there's more consistency in these PA submissions. And including the patient in the PA planning or process I feel like is a must. We do hear from time to time the patient complain that their medication is not covered, when in fact it just requires a prior authorization. And it gives them a little bit of understanding that their provider and their health plan are working together to get their medication. So that's good to include them in the process as well. And finally, when a PA is denied, it's good to have a plan or a reviewer of these denials. Our PA reviewers will indicate on the denial why the PA is denied. From sometimes it'll be as simple as, we didn't receive such information, or it's a wrong indication or whatever. That's a good item to follow up. If it's an easy fix, maybe your staff can just send the right documentation or resubmit the PA with the correct information. But if it's more than that, maybe a more robust clinical rationale is needed, then that can also be included in the follow-up as well. So having a denial does not mean it's the end of the PA process. It just means that maybe there's follow-up that needs to happen. And thank you for your time. Like I said, it was just going to be a very brief summary of a PA. And if you have any questions, please include it on the chat line, and thank you.
Well, that was quite a lot of really focused content here today. I'm just checking our time, and we do have a few minutes remaining here, and incredible generosity on the part of our presenters, giving you full access today, which could be a rare thing sometimes. So while we're waiting for any questions to come in, I would also like to encourage our panelists today and our presenters. You've been in these kind of siloed little areas so often as we've prepared this show today. If you have things you want to ask each other and get perspective on, and kind of remark or comment on each other's content, I think this is a great chance to do that too, to reinforce some of these key points. Feel free. I'll leave it to you folks to jump in here. Dr. Remick, did you have any questions you wanted to ping off of everyone?
Thanks, Paul. Actually, Jason, I was going to ask you a question with regards to the formulary requirements for these medications, how it requires a cardiologist to prescribe them. Is there any talk about lifting that requirement so that our primary care colleagues can get these medications going before they get in to see a cardiologist?
So the intention of the requirement of a cardiologist being the prescriber really was to make sure that the patient can have the proper specialist to oversee their heart failure early on in their disease process. We do consider a consult from a cardiologist. We do take that into our review as well, and we do see sometimes that where a scenario where the primary care will take on like refills or initiating the prescription on behalf of a cardiologist consult. So that is, it's kind of more of a just an initial awareness, like, hey, you want to make sure that the patient with a heart failure, especially the ones that are kind of early on in their disease process, get the proper specialist involved. But we do take into consideration, even if it's not prescribed, just having a cardiologist involved in the team is very important. Does that answer your question, Dr. Remick?
To add to that a little bit, I frequently work with a group of our internal medicine providers and as a liaison between the cardiology department. So I coach them to put in their notes consulted with cardiology team as part of that, so that we don't run into therapeutic inertia as we're up titrating, because maybe our office isn't open or doesn't have openings for a patient to get in, but maybe their office does. And if we work together collaboratively, we can get a patient to those doses.
Exactly.
That's great. So just having that reference, saying that there's been this communication and that there's kind of a hand in glove perspective there, just that thing in and of itself can be like a really good kind of best practice to be able to integrate and just kind of streamline things, which is perfect. So that's great. And I'm just checking in real fast on our Q&A thread here today. I think everyone has been wrapped and getting all this content here. So I'm not seeing a lot of stray questions yet on here. We got so many different perspectives here this morning, friends. I was really grateful for all of your time and this all coming together. Did either of you have any stray questions or other pending items you wanted to ask each other? This is a great opportunity to put anything out there. Is there as we look forward to like coming out of the pandemic now, fingers fully crossed at this point, right? And getting more awareness about these new medications. Are there concerns about the future that any of you have as far as what you think is coming, or things that folks in primary care should be taking more of an aggressive stance towards doing?
As a pharmacist working kind of frontline on some of these, I just always want primary care to know that there's a lot of resources out there for patients who can't afford it. Our Medicare group probably has the biggest hurdles for cost compared to any other group. They can't use the copay cards. That'll decrease their month-to-month costs. The Medicaid patients, if they meet criteria, their copays are usually pretty affordable. You just have to go through the hoop of the prior authorizations. But the Medicare people really run into some problems. And we still have this dreaded gap phase for a couple more years, where maybe if things go through the way they're supposed to, we'll be down to a $2,000 out-of-pocket max. But when many of our Medicare patients are limited to only having Social Security and they only bring in $2,400 a year, $2,000 out of pocket for drug costs is insane. There are quite a few options. It just requires a little bit of paperwork, but quite a few options to get free medications from manufacturers for the SGLT2s and for Entresto. So I know that for Jardiance, if you're at 250% of the federal poverty level, then you qualify. It's about 400% for Farxiga and also for Entresto to qualify for their assistance programs. And so roughly speaking, it's about $35,000 a year for Jardiance and about 450-ish, 55 for the other two. But these applications are available online. You fill it out. Sometimes they have to show proof of income, so their Social Security statement and their insurance card and a signature from a doctor, and that's all there is. And the drug comes straight from the manufacturer free of charge. So there's options out there. A couple times a year, there are scholarships out there that patients can apply for that are between $1,000 and $1,200 a year that our Medicare patients can get, that will just go to paying their gap copays. Some patients will get it early in the year, and there's ways to find this online through Fund Finder, which is a nonprofit that will go and search for these funds. But they're all options, and the Fund Finder funds, when they open up, they go pretty fast in a month or two. But many patients can get some pretty good assistance that gets them through the gap phase. And the cutoff for income is a bit higher for that one than the free manufacturer program. So keep your eyes out, search for those. They are available, and the paperwork isn't that bad. I do that in clinic all the time with our patients, and it takes a couple weeks to get done, but it's very achievable.
Fund Finder, that is fantastic. I want to make sure that our audience gets the link to that too, so that they're able to. Is that that's through the PAN Foundation? It looks like.
Yes, sir.
Excellent, excellent, fantastic. That's something I had never heard of myself. So I think it's great to be able to, you know, show some focus on those options that I think a lot of people just don't know that are out there. So I think it's fantastic information and everything. And I'm just looking at our clock here and want to be mindful of the time on here, but I think we are in great shape. Our audience has been very more content to listen than ask a lot of direct questions here today, but I think a lot of that may be because your content was so thorough. I think you didn't leave a lot of ambiguity or room to have dangling threads that needed to be followed up on. So I think it's a huge amount of great information, especially when we share the slides out today to everybody. I think they're going to get a lot of great resources to refer back to. And hopefully this is going to be something that really helps primary care dive in a lot deeper and make sure they're more current on what the options are for heart failure treatment. So I would just like to, on behalf of our audience and everybody here at CareOregon, friends, just thank you all to our presenters for being so kind and exhaustive with your knowledge and all the work you put into this. This is a sensational session that we were able to put together today. So thank you for making time to do this. To our audience, I just want to give a couple of little closeout details here for you as we sign off here at the bottom of the hour today. Again, we'll be sending out all of these slides this afternoon, along with any additional resources that surface here as well. As a reminder, the next scheduled MedZed, now sometimes these MedZeds happen suddenly without a lot of warning, but the next one we have firmly scheduled is a great one for mid-September, helping grapple with the ongoing issue of health literacy and numeracy that we mentioned earlier, to make sure that we're able to communicate the cartoon that Tina shared there about keeping it simple, right? I think that's something that always behooves us to keep in mind, because otherwise it could be extremely challenging from a patient's point of view to understand and grapple and retain a lot of the things that we're starting to convey to them, especially when medications get into the mix. It's like an entirely different language. So this is going to be a great session that focuses on that. I encourage everyone to go ahead and enroll in that now. And you can also visit our program webpage for recordings of all of these MedZed sessions. Everyone who enrolled by email here today will be getting a real short, simple survey, regardless of which kind of credit that you need. You just simply fill that out, make sure that your email is in there correctly. And then early next week, we'll be sending out copies of all the different CME and CEU certificates that we prepare for you. So you'll have all the credit you need and everything will be in great shape. So I'd like to once again thank our presenters here today, and to thank Ian Youngstrom and Laurie Morey and everybody in the tech side of the fence here with video production and audio. We've been really having good luck with this, the new Teams product here. No technical issues at all. So it's a great innovation, and we're really happy to be able to employ that, and grateful for everyone's help on the production side of things. That's all we have for this morning, folks. So again, thank you for your time and for your interest in trying to provide better care for those impacted by heart failure in Oregon and beyond. It was great to be able to spend a little time with you, and we very much here at CareOregon appreciate everyone's efforts and everything you do to improve the health of so many people in the state of Oregon. So thank you for spending time with us today, and we'll see you at our next presentation, folks. Have a great rest of your day, and thank you. We'll talk to you soon.